Welcome to another deep dive. Imagine a patient you're caring for. They're struggling with mood swings, difficulty focusing, maybe even physical pain. You might immediately think about medication, perhaps therapy. But what if the real culprit isn't what you expect? What if it's something as fundamental yet often overlooked as their sleep? Today, we're taking a deep dive into how understanding sleep holds a crucial key, really, to unlocking better health outcomes, especially in psychiatric nursing. Our guide is a vital chapter from Varkarolis' Foundations of Psychiatric-Mental Health Nursing, a clinical approach, that's the 8th edition, by Margaret Jordan Halter. And this isn't just about, memorizing facts. It's about mastering how to assess, diagnose, and truly intervene when sleep goes awry.
Exactly. This deep dive is really designed to equip you with the professional accuracy you need. Things like mental health assessment, therapeutic communication, understanding major psychiatric disorders,
Yeah.
psychopharmacology, and evidence-based interventions, all as they relate specifically to sleep. We'll be connecting these concepts directly to, well, real-world nursing responsibilities and even those NCLEX testing priorities.
Right. So think of this as your essential roadmap to understanding sleep-wake disorders holistically, step by step, complete with practical examples and the critical why it matters behind every concept. Let's unravel this together. So let's begin with the elephant in the room. Why is sleep such a huge deal beyond just feeling a bit groggy? The chapter really emphasizes sleep as a, quote, key determinant of health and well-being. What happens when we simply don't get enough?
Well, the ripple effect of insufficient sleep is just widespread. It impacts both physical and mental health pretty significantly. The immediate, tangible consequence of, let's say, acute or chronic sleep curtailment is excessive sleepiness. Now, this isn't just a subjective feeling. It can severely impair social functioning, work functioning, and dramatically increase accident risk. What's truly unsettling is that daytime wakefulness exceeding 17 to 19 hours can produce psychomotor impairments equivalent to a blood alcohol concentration of 0.05% to 0.1%.
Wow. 0.1%.
Yeah, often above the legal driving limit. Just imagine the implications of that.
That statistic alone is a real wake-up call. And the financial impact of poor sleep you mentioned, it's
Sure.
not insignificant, is it?
Not at all. This staggering $63.2 billion annual cost just for chronic insomnia isn't just a number. It's a stark reminder that sleep isn't some kind of luxury. It's a fundamental public health and, yes, economic driver. Think about the historical tragedies the chapter cites, like the Exxon Valdez grounding or 3 Mile Island. These were directly linked to human error and fatigue caused by sleep loss. So as nurses, understanding this economic impact, well, it elevates our advocacy for sleep interventions beyond just individual patient care to a systemic priority. And this is a critical insight for you as future mental health nurses. Sleep deprivation is a master of disguise. Its symptoms so closely mimic psychiatric disorders like mood disturbance, increased pain perception, impaired cognitive function, memory disturbance, that without a thorough sleep assessment, we risk misdiagnosing and, frankly, mistreating. You really need to consider sleep as a primary differential, not just a comorbidity.
Right. So it's far more than just feeling tired. We're talking about significant long-term health risks. The chapter points out a twofold increased risk of obesity, diabetes, hypertension, cardiovascular disease, stroke, depression, even substance use. For those consistently sleeping less than 6 or, interestingly, more than 8 hours, that's quite a wide net.
It is. And to truly grasp sleep disorders, we first need to understand the blueprint of normal sleep. It's a dynamic neurological process, beautifully categorized into 2 main states, non-rapid eye movement, or NREM, and rapid eye movement REM sleep. Both are measured via electroencephalogram, or EEG, which gives us a peek into brain activity.
Okay. Could you walk us through the different stages of this fascinating process?
Absolutely. So NREM sleep has 3 distinct stages. Stage 1, N1, that's that brief transition as you're drifting off, maybe 2–5% of total sleep. Your body temperature begins to decline, muscles relax, and your eyes do a slow rolling movement. You're easily roused here. Then we move into stage 2, N2, which dominates most of our sleep time, about 45–55%. Here, your heart and respiratory rates continue to decline, and it takes more stimuli to wake you up. Finally, stage 3, N3, often called slow-wave sleep or delta sleep, accounts for 13–23% of total sleep. Your vital signs reduce even further here, and this is considered a truly restorative sleep, largely due to significantly reduced sympathetic activity.
Okay, restorative. That's N3.
Correct. Following NREM, we enter REM sleep, which makes up maybe 20–25% of our total sleep. This stage is characterized by muscle atonia, a fascinating loss of muscle tone that's thought to be protective, preventing us from acting out our dreams. You'll also see rapid eye movements, facial and limb switches, and of course, vivid dreaming.
That muscle atonia is really interesting, protective.
It is. A normal adult sleep period typically begins with NREM, and then we cycle between NREM and REM roughly every 90 to 120 minutes throughout the night. Interestingly, NREM sleep tends to dominate the first half of the night, while REM becomes more prominent in the second half. This predictable pattern is called sleep architecture, and it can be visually represented by something called hypnogram. Any disruption, like, say, too much stage 1 sleep or frequent awakenings, is what we refer to as sleep fragmentation.
Okay, architecture and fragmentation. So if that's what normal sleep looks like, what precisely is pulling the strings behind the scenes to make it all happen? How is sleep actually regulated?
Ah, yes. It's a complex, elegant interplay of two primary processes. First, there's the homeostatic process, which is essentially our sleep drive. Think of it like pressure building up. The longer you're awake, the stronger that drive for sleep becomes. Then we have the circadian process. This is wake promoting and operates on near 24-hour cycles. This is our internal master clock, located in the suprachiasmatic nucleus, or SCN, of the hypothalamus. External cues, known as zeitgebers, things like light and darkness, are crucial for setting and resetting this internal clock.
Zeitgebers. Okay.
And neurotransmitters also play a vital role. Think of dopamine, norepinephrine, serotonin, acetylcholine, histamine, glutamate, and hypocretin as the gas pedals for wakefulness, keeping you alert. On the flip side, adenosine, GABA, and galanin are more like the brake pedals for sleep, promoting drowsiness and helping you drift off. It's truly eye-opening when you connect this to the bigger picture. Psychiatric medications often modulate these very systems, which explains why they can have such a profound and sometimes unexpected effect on sleep.
That makes so much sense. With that foundational understanding of normal sleep, it becomes much clearer how things can go wrong. Let's pivot now to the specific disorders you'll most commonly encounter, starting with, I guess, the most common one, insomnia.
That's right. Insomnia disorder is characterized by a significant dissatisfaction with sleep quantity or quality. The DSM-5 criteria define this as difficulty initiating sleep, difficulty maintaining sleep, frequent awakenings or early morning awakening with inability to return to sleep. These symptoms must occur at least 3 nights per week for at least 3 months, cause significant distress or impairment, and not be better explained by other medical conditions or substances.
3 nights a week for 3 months. That's specific.
It is. For assessment, nurses often utilize Spielman's 3P model. This framework is incredibly helpful for understanding the contributing factors. There are predisposing factors. These are individual vulnerabilities, like being a light sleeper or having a personal history of depression or anxiety. Then, precipitating factors, the external events that trigger the insomnia, such as acute stress, a new medical illness, or maybe grief. And finally, perpetuating factors, these are the habits or behaviors that maintain insomnia over time. Things like excessive caffeine intake, chronic napping, or constantly worrying about not being able to sleep. Understanding these really helps us guide targeted interventions.
That 3P model sounds incredibly useful for digging into the root causes. What about some of the other key sleep disorders we should be aware of?
Certainly. First up, hypersomnolence disorder. This is marked by excessive daytime sleepiness, recurrent periods of sleep or napping, often a prolonged main sleep period of 9 or more hours, and sleep that simply isn't restorative no matter how long it lasts. This leads to impaired functioning during the day. Treatment typically involves establishing regular sleep schedules and sometimes stimulant medications.
9 hours or more and still tired. Wow.
Exactly. Then there's narcolepsy, which is defined by an uncontrollable urge to sleep. It's frequently accompanied by cataplexy. That's a sudden, brief loss of muscle tone, often triggered by strong emotions like laughter or anger, while the person remains fully conscious. Imagine a sudden collapse, but you're still aware. It's essentially REM sleep paralysis occurring during wakefulness.
That sounds incredibly disruptive and honestly quite dangerous. I'm reminded of the chapter's poignant example of comedian Mike Birbiglia, who literally acted out dreams falling off a bookcase or, I think, jumping from a hotel window. That truly brings home the safety concerns.
It does. That particular vignette highlights how REM sleep behavior disorder can manifest, which can occur alongside narcolepsy. For narcolepsy itself, treatment strategies include scheduled naps, regular exercise, a balanced diet, and specific stimulants, or sodium oxybate, which can help with both the sleepiness and the cataplexy.
Okay, what's next?
Moving on, we have breathing-related sleep disorders. The most common among these is obstructive sleep apnea-hypopnea syndrome. This involves repeated upper airway collapse during sleep, leading to loud snoring, witness pauses in breathing, and critically excessive daytime sleepiness. Diagnosis is typically confirmed by an overnight polysomnography, a sleep study, and the primary treatment is continuous positive airway pressure, or CPAP.
Right, CPAP. The vignette about Sarah, the patient with schizophrenia, really emphasized this. Her weight gain from clozapine led to severe obstructive sleep apnea. It was confirmed by polysomnography, and once treated with CPAP, she returned to her baseline functioning. That's a powerful example of how interconnected physical and mental health are in practice.
Absolutely, it's a great illustration. Beyond obstructive apnea, there's also central sleep apnea. This is where the brain temporarily stops sending signals to the muscles that control breathing, leading to a cessation of respiration. And then sleep-related hypoventilation, characterized by sustained oxygen desaturation during sleep, often without complete apnea.
So the brain just stops telling the body to breathe.
In central sleep apnea, essentially yes, the respiratory control center falters. Next up, circadian rhythm sleep disorders. These occur when there's a misalignment between a person's internal biological clock and external environmental factors. Common examples include delayed sleep phase type, really common in adolescents, the night owls. Advanced sleep phase type is the opposite, seen more in older adults, the early birds. Irregular sleep-wake type is often associated with neurological conditions like Alzheimer's. Non-24-hour sleep-wake type is a significant challenge for blind individuals who can't perceive light cues to reset their clocks. And finally, shift work type, which causes that excessive sleepiness while on the job and impaired sleep at home. Major issue for nurses, of course.
Yeah, definitely relevant for us.
Then there are the non-rapid eye movement, or NREM, sleep arousal disorders. These include sleepwalking somnambulism and sleep terrors. Because individuals in NREM sleep don't have that protective muscle atonia we talked about, they can engage in unsafe activities. So for these, safety measures and strict sleep hygiene are really key interventions.
Safety first. Makes sense.
Nightmare disorder involves long, frightening dreams from which individuals awaken feeling scared and distressed. These typically occur during REM sleep, often later in the night.
Different from sleep terrors, then.
Yes. Sleep terrors happen in NREM, often with no dream recall, just intense fear and autonomic arousal. Nightmares are in REM, with recall of a scary dream. And then there's rapid eye movement, or REM, sleep behavior disorder. This is where patients literally act out their dreams because they lack the normal muscle atonia during REM sleep. It's most common in elderly men and can actually be an early sign of underlying neurological conditions like Parkinson's disease. The chapter shares that powerful vignette of an 80-year-old man with Parkinson's thrashing in bed, injuring his wife while dreaming of an intruder. This powerfully underscores the critical importance of safety for both the patient and their partner.
That's terrifying. The potential for injury is really high.
It can be, yes. Finally, we have restless leg syndrome. This is a sensory and movement disorder defined by uncomfortable, often described as creeping or crawling, sensations in the legs, accompanied by an irresistible urge to move them. These sensations are worse at rest, temporarily relieved by activity, and typically worsen in the evening or at bedtime. It profoundly affects both sleep onset and maintenance. Often it's related to dopamine dysfunction or an iron deficiency.
Kathy's story from the chapter really brought that to life. She described her restless legs like soda pop fizzing through my veins, which led to anxiety and pacing, making sleep impossible. That vivid description truly highlights how these symptoms devastate quality of life, and how effectively they can be addressed with targeted medications like dopamine agonists.
Exactly. That patient description is very memorable. And one final, yet incredibly common category, substance-induced sleep disorder. This results from the use or recent discontinuance of various substances or medications. For example, alcohol, despite initially inducing sleep, actually decreases deep and REM sleep, leading to middle-of-the-night awakenings and fragmented rest. Nicotine is a central nervous system stimulant keeping people awake, and caffeine works by blocking adenosine, a key sleep-promoting neurotransmitter. It's absolutely crucial for nurses to conduct a thorough assessment of a patient's substance use when evaluating sleep issues.
That makes perfect sense. Everything is so interconnected. And speaking of interconnectedness, how often do these sleep disorders exist in isolation, or are they usually found alongside other conditions?
That's a great question. And it's vital to recognize that sleep disorders, well, they really exist in isolation. Many actually increase the risk for serious medical conditions like hypertension, diabetes, cardiovascular disease. Furthermore, neurological diseases like Alzheimer's and Parkinson's often see worsening sleep disturbances as they progress.
Okay, medical conditions. And what about psychiatric disorders? Is there a strong link there, too?
An incredibly strong one. Virtually all psychiatric disorders, especially major depressive disorder and bipolar disorder, are associated with significant sleep disturbance. Sleep disruption can even be a precipitating factor for triggering mood and other psychiatric disorders and dramatically increases relapse risk. Importantly, depressed patients with sleep disturbances show greater suicidal ideation, making identification and management of sleep issues absolutely critical for patient safety.
Wow, that link to suicidal ideation is critical.
It absolutely is. The chapter even highlights a study on adolescents and young adults linking a delayed midpoint of sleep and attending evening classes with depression, particularly in females. This really emphasizes how nurses can counsel patients on finding balance to minimize stressors impacting their sleep.
Right. This brings us to the core of our discussion. Applying the nursing process to sleep disorders, how do we put all this knowledge into action?
Indeed. Regardless of the clinical setting, every patient benefits from a sleep evaluation. Nurses are 247 care providers, placing us in the ideal position to assess and educate.
Often, patients don't walk in and say, I have a sleep problem. They might complain about fatigue, irritability, or mood disturbance. So, during assessment, how do we effectively get to the root of a potential sleep issue?
It's crucial to recognize the 24-hour nature of sleep disturbance. One of the most insightful tools we have is a 2-week sleep diary. As a nurse, you'd instruct a patient something like this. Okay, for the next 2 weeks, I want you to keep track of your sleep patterns. Each day, note the date, whether it was a work day, day off, etc. Record any coffee, meds, alcohol, or exercise you had and when, then mark the time you got into bed. Shade in the boxes for when you think you were actually asleep, both at night and any naps. Leave the boxes blank for times you were awake in bed or during the day. This comprehensive record over 2 weeks helps us identify clear patterns and contributing behaviors that a patient might not even realize are happening.
That diary sounds like a really powerful visual tool.
It is. We also use targeted screening questions. For insomnia, you might ask, do you have difficulty falling asleep, staying asleep, or waking up too early? For sleep apnea, has anyone ever told you that you snore loudly or stop breathing in your sleep? And for restless leg syndrome, do you ever get unpleasant feelings in your legs like crawling or tingling, with an urge to move them, especially at night? These questions open the door to deeper conversation.
Simple questions, but they get right to the point.
Exactly. For more objective measurement, nurses employ tools like the Pittsburgh Sleep Quality Index, or PSQI. A global sum of 5 or greater on this scale generally indicates poor sleep quality. And the Epworth Sleepiness Scale, or ESS, measures subjective daytime sleepiness. Scores of 10-15 suggest moderate sleepiness, and anything over 15 indicates excessive sleepiness. It's also worth noting, as nurses, we are vulnerable to sleep issues due to shift work. Self-assessment and prioritizing our own sleep hygiene are critical not only for our well-being, but for patient safety and competent care.
A good reminder for all of us. So once we've gathered all this assessment data, how do we translate that into specific nursing diagnoses?
Well, the chapter outlines 4 key NANDA international diagnoses for sleep disturbance. First, there's insomnia itself, signifying a disruption in the amount and quality of sleep that impairs functioning. Second, sleep deprivation, indicating prolonged periods without sleep. Third, disturbed sleep pattern, which refers to changes in sleep routines that cause impairment. And fourth, readiness for enhanced sleep, which applies when a patient expresses a desire to strengthen their healthy sleep patterns.
Okay, 4 key diagnoses. Then we plan.
Right. From there, we use the Nursing Outcomes Classification, or NOC, to identify our desired results. These could be things like improved sleep induction, achieving appropriate hours of sleep, establishing consistent sleep patterns, or the patient simply reporting feeling restored after sleep. These outcomes give us clear, measurable targets for our interventions.
Makes sense. Most sleep disorders are managed in the community, often with a multidisciplinary team. As a nurse, what's our pivotal role in the intervention phase?
Our counseling role begins right from that initial assessment, providing crucial support and, importantly, assurance that sleep problems are indeed treatable. Many patients feel hopeless, and it's our job to counter that with encouragement and realistic hope. Health teaching and promotion are absolutely paramount because so many people underestimate sleep's profound importance. We educate on key sleep hygiene principles, maintaining a regular sleep-wake schedule, especially consistent wake time, developing a consistent pre-sleep routine that signals the end of the day, reserving the bedroom for sleep and intimacy only, no TV, no work in bed, creating a conducive environment regarding light, noise, temperature, avoiding clock watching, that just increases anxiety, limiting evening caffeine and alcohol, avoiding heavy meals right before bed, exercising daily but not too close to bedtime. And we also emphasize reducing technology use before bed, that blue light is a real issue.
So much practical advice there. What about sleep restriction? That sounds a bit intense.
It can sound counterintuitive, but it can be very effective for insomnia. The idea is to temporarily limit time allowed in bed to approximate the time the person is actually sleeping. This creates mild sleep deprivation, which strengthens the natural sleep drive, that homeostatic pressure we talked about. Then, as sleep efficiency improves, meaning less time awake in bed, we gradually increase the allowed time in bed by maybe 10 to 20-minute increments. Patients must, however, be very carefully cautioned about driving or operating machinery while feeling sleepy during this initial phase. Safety is key.
Right, safety first again. Given this emphasis on non-pharmacological interventions, where do medications fit into a nurse's toolkit for sleep disorders? Are there common misconceptions or risks we need to be particularly aware of?
That's an excellent point. Pharmacological interventions are typically recommended for short-term use, usually no more than 2 weeks. This is mainly due to concerns about developing tolerance where the drug becomes less effective and potential withdrawal symptoms when stopping. We educate patients thoroughly on the benefits, potential side effects, and adverse effects of any prescribed sleep medication. And while hypnotics are certainly part of the treatment landscape, it's really worth emphasizing that non-pharmacological treatments like CBTI often show superior long-term efficacy.
You mentioned CBTI.
Yes, cognitive behavioral therapy for insomnia. Somatic interventions also exist. For example, the Cereave sleep system is an FDA-approved bedside device. It works by cooling the forehead, which can reduce activity in the cerebral cortex and help quiet those racing thoughts that often interfere with falling asleep.
Interesting technology.
It is. And for dance practice nurses especially, CBTI is considered the gold standard, highly effective treatment for chronic insomnia. It's a comprehensive approach involving education, behavioral interventions, and cognitive restructuring. A key behavioral intervention is stimulus control. This adheres to 5 core principles. 1. Go to bed only when truly sleepy. 2. Use the bed or bedroom only for sleep and intimacy, no TV, reading, eating, or working in bed. 3. If you can't fall asleep fairly quickly, say within 20 minutes or so, get out of bed. Go to another room and do something quiet and non-stimulating, like reading under dim light until you feel sleepy again, then return to bed. Repeat as necessary. 4. Maintain a regular sleep-wake schedule with a consistent wake-up time being the most crucial factor, 7 days a week. And 5. Avoid daytime napping. If a nap is absolutely necessary, keep it short, maybe 20 to 30 minutes maximum, and not too late in the day.
Those stimulus control rules sound strict, but I can see how they'd break negative associations with the bed.
It's exactly.
Yeah.
CBTI also includes cognitive restructuring to help identify and correct maladaptive beliefs and attitudes about sleep, like catastrophizing about a single bad night's sleep. Through these combined strategies, nurses empower patients to gain a sense of control over their sleep rather than feeling controlled by their sleep difficulties. It's very empowering.
That sounds like a powerful way to empower patients. So how do we know if our interventions are actually working? How do we evaluate success?
Evaluation is based on both objective changes, things we can measure, like decreased sleep latency, so how long it takes to fall asleep, fewer nighttime awakenings, improved daytime sleepiness. These are often tracked consistently via that sleep diary we discussed earlier. But equally, if not more, important is the patient's perception of improvement. Do they feel less controlled by their sleep difficulties? Do they feel more confident in their ability to manage their sleep through their new routines and practices? Their subjective experience is absolutely paramount.
Subjective experience matters.
Got it. This deep dive into sleep-wake disorders really drives home how foundational sleep is to overall health, doesn't it? And how critical the nurse's role is in assessment, education, and intervention. It's clearly not just about treating symptoms, but truly empowering patients for better quality of life.
Absolutely. Understanding sleep physiology, being able to identify the various disorders, and skillfully applying the nursing process from assessment all the way through evaluation. This equips you to provide truly holistic, patient-centered care. Remember, sleep health is recognized as a national priority, and nurses are truly instrumental in advancing those goals.
So as you continue your journey in mental health nursing, remember to consider sleep almost like a vital sign. It's a key that can unlock better outcomes for your patients and, frankly, even for yourself.
So the question to leave you with is, how will you integrate this comprehensive understanding of sleep into your practice? Not just seeing it as another symptom to treat, but really viewing it as a pathway to patient empowerment and overall well-being. Thank you so much for joining us on this deep dive. We really hope this has been a valuable last-minute lecture as you build both your knowledge and your empathy as future mental health professionals. We appreciate you tuning in.